So for those of you that don't know me, my name is Mark Russell. I'm a FACEM by training and a registrar here. This is I'm just going on to my second year, and still convinced this is the best job in the world. So I'm continuing to live the dream. And today we're going to talk about resuscitative hysterotomy. Had a case about 4 weeks ago now, and just some reflections about that case and an opportunity to share some of my thoughts about it. And see what you guys think. So we're just going to talk about the case and then some reflections, and at the end, just a little bit of a Q&A if anyone has any questions. So resuscitative hysterotomy is something we learn in induction, but by far and away, it's a pretty unique occurrence. The last time we had a procedure like this was back in around 2010. A pre-hospital resuscitative hysterotomy that was published in the European Journal of Emergency Medicine. Roger Bloomer, I think, was the registrar involved at that time, published a paper with Cliff, and I think Rod Wheatley was also involved. And this is really one of these high acuity, low occurrence procedures, and is a good opportunity because they're so rare, perhaps just sharing it amongst the service so that we continue to build upon what we've learned. And so I'm just going to run through the case with you guys, just to set the stage for what happened, and it's just an account of what happened, and then we'll move through and have a chat. This is I'm not going to teach you how to suck eggs. I think everyone here is more than competent to perform the procedure, so I'm not going to emphasize any details about that, more just any nuances or changes that I see that might be of benefit. So there's Graham and I. It's 4 in the morning. We're transferring our initial case, which was a sick ventilated steroid-resistant dermatomyositis. Stable, but on at least 80% oxygen. Was a decently unwell lady, but a short transfer from Bankstown. And we're listening to our Smooth FM on the way into Liverpool, and we get a call, just so you're aware. And always a nice call to have when you're not expecting it. And we're told that not a formal tasking, but just to be aware that there is a case coming. And for those of you that aren't from Sydney, this is, that's just the slide, you can leave it there. Yeah. For those that aren't from Sydney, so Bankstown is not too far from Liverpool, and it's about a 15-minute drive or so. And we're told that there's a 32-year-old female who's suspected to be about 37 weeks pregnant. That turned out not to be true, but she'd had an eclamptic episode at home, and she was now in cardiac arrest. She'd had a seizure initially with incomplete recovery and initial blood pressure that was told to us to be about 220. That actually turned out to be about 260 that came out in the wash. And we suspect that she had a hypoxic arrest or potentially an intracranial event. But this is what we were told. And she was now in arrest. She was 5 minutes or less than 5 minutes in arrest, and she was getting CPR, and she was going to be in Liverpool shortly. They'd managed to start CPR, put in LMA, and they were following a PEA systole algorithm. And so from that point and that point onwards, the clock is really ticking. So I'm sure a lot of you guys will be aware, and we'll talk about it more in a moment. But it was well and truly a factor in this case, and very prevalent in our mind as we work through. So we arrive at Liverpool, and very concurrently, we just before we'd started to offload, our patient was already out, and the crew bringing in the out of hospital cardiac arrest. Graham jumped out and just checked on that crew, made sure that they were set, and so started facilitating them moving into the resuscitation area. And then I moved my patient with one of the ICPs into the resuscitation area. For those that, I'm sure a lot of you have been to Liverpool in the past, but there's an area just by that red door, essentially where I parked my patient, and just left my patient with one of the senior registrars, or at least one of the ED registrars, who very kindly agreed to keep an eye on my patient. We optimized her just for stability, so just made sure she had an adequate amount of blood pressure, and just said, we'll be just over there if you need us, and asked them to give ICU a call and see if they could come down. They were already coming down for the case anyways, and so they were going to be able to give us a hand taking that patient up. We'll do handover a little bit later. And then approached the scene, and it was a very busy scene, and everyone had been called. So there was ED, there was ICU, there's NICU, there's anesthetics there, nursing, midwifery, and obviously the pre-hospital team. Initially, when we'd spoken to them, there was a suggestion that everything was in hand, and it really was, except that O&G weren't actually there. So we reapproached them and said, "Oh, listen, we have some skills. We're here. We're available. Would you like our assistance?" And initially, I think there was some hesitation because they didn't know exactly what our skill set might have been. But we identified ourselves as the HEMS team and had the capability to perform the procedure, had the training, and were happy to proceed. At which point, they sort of very happily gifted us the scalpel. And I think that was a moment where it was just a transition, I suppose, metaphorically and physically, of that procedure to us. And so we integrated into the team and did our first assessment of the patient at that point. And just to timestamp that was probably about 13 minutes of downtime. Not downtime, I guess low flow time, whatever you want to call it. And so this assessment was probably done in a matter of seconds, but we could see both from the missed call and from our assessment that her airway had an LMA. There's an anesthetist at the top end, and he appeared to be doing something, but wasn't quite sure what it was happening. CPR was ongoing, and they were bagging the patient, but not very effectively. And perhaps mentioning at this state that the most dramatic thing that you realize about this patient is she was massive. I wrote 120 kilos on the case sheet. I suspect she was probably more like 160 to 180 kilos. So quite easily a lady that in the next iteration of the induction, we just increased the size of the patient that gets hit by the bus. But anyways, CPR is ongoing, and at that stage, we're still in a PEA asystole algorithm. About 10 to 15 minutes of low flow state. She's had some adrenaline, and because she's so big, it's manual compressions only. She's got fixed and dilated pupils, and she's got a very large obese abdomen, which is consistent with a pregnancy that's at least more than 20 weeks, and certainly suspected higher than that. They're having some difficulty with intravenous access, and so they're getting ready to start drilling her. And I think they'd had an IO at that stage in her shoulder or anterior tibia. So very quickly, our impression: this is a late stage pregnancy with an out-of-hospital cardiac arrest. She's actually had a pretty decent end-tidal CO2 at that point. It was about 42. And we suspected this was an eclamptic episode with incomplete resolution, potentially an intracranial event, and a low flow state, which was probably about 10 to 15 minutes, but with good bystander CPR from the paramedics. There was obvious clinical indications for resuscitative hysterotomy at this case. So maternal cardiac arrest for more than 4 minutes with a pregnancy that's over 20 weeks, or if you don't know, a uterus which is above or up to the umbilicus. And so at this stage, there was a pause point or a conversation between myself and Graham, and it was, yep, okay, we're on. And so we got gounded up, and they talk about having a 3-team model, and I kind of like a 4-team model. And we divided ourselves up. So we had active team leading from the Liverpool team, and they did a fantastic job. And so the senior regs there continued to manage the case entirely. We were going to be task focused, and we moved ourselves to the resuscitative hysterotomy. Anesthetics were in charge of the airway, and then NICU was setting up the resuscitator ready for the baby's delivery. And the plan that we just verbalized was that anesthetics was going to put in a tube and potentially some large bore access. NICU was available and ready to receive the baby. And if ONG showed up, then they were going to assist us with our procedure. The plan from the team leader was to continue resuscitation following the PEA algorithm and add appropriate agents where we could, including magnesium and potentially some oxytocin and some other things, which you'll see in a moment. And so we get handed this, which I don't know if you guys have ever seen before, but apart from maybe recognizing some torture devices, very unfamiliar with a lot of the things in there. And this is all we ended up using. And in training, I think we get taught the procedure, and it includes a pair of scissors. But I think this is really all you need, and then lots of hands, and that's all that we ended up using. So, it's a procedure which is actually very straightforward in its actual manual dexterity in the way in which you do it. And it really just requires a sort of a step-by-step approach. And for a lot of us, I think we've been through it 1,000 times in our minds, and we've kind of developed a muscle memory of how to do it. And really, I think the way I approached it was just the next step and focusing on the next step as we progress through. And so just to walk you quickly through exactly what happened is we gowned it up. We had our drapes on, we had our surgical gloves on, we already had our PPE and some eyewear. I don't even remember if we did a splash of Chlorhex or anything. But the first thing that was perhaps most notable is the wedge went in as you would normally do for this type of case, with some left lateral tilt, which is a discussion we'll have a little bit later on. It's probably something I wouldn't do in the future. But with the size of this patient, it made the midline, or the incision line that we actually did, was probably paramedian. So we actually did an incision not through the umbilicus, but through where we sort of imagined the spine to be, and down through the abdomen. And there was quite a lot of adiposity. And so our incision was big, and it was zippy down to pubis, and we resected as we went. And we only paused the compressions twice, once for the initial incision and then the second time as we entered into the uterus. And the reason was, those are the points at which I think you can agree there's some sort of, we wanted to make sure that we got it right. The tilt made things challenging, both for the incision, but also for the compressions, because you had these people, that big lady trying to lean over her and adequately center on the chest and do CPR. And this is a lady that would only really receive 10% of her cardiac output from those compressions, given how pregnant she was. So something we'll chat about later. One of the things that struck me most about this whole thing was, in your mind, and if you've ever simulated this, you often do it on cadavers. And I was really taken that the patient was quite warm. And so that was one of the things, the most tangible things that I took away, is you simulate in your mind, and you don't actually think about it. This is a very much alive, or we're attempting to resuscitate. This patient's currently in cardiac arrest, but it's a warm patient, but she's not in a flow state, and so she doesn't have any perfusion, and so things aren't as you'd expect. So when we entered into the abdomen, we thought that the uterus was going to be this pink, very, muscular sac. And in actual fact, it was not at all. So it was sort of very dark, potentially sort of, I don't want to say gray, but it was definitely a cyanotic type uterus. And it was not a muscular sac at all. It was really quite an atonic uterus that was just saggy in some ways. And so it was very easy to pick up and open into it. And we kept in a midline, and just as we'd sort of done our incision into the uterus, we saw another pair of green hands sort of entering into the field, and the ONG team had arrived at that stage. And very quickly, we managed to rupture the amniotic sac and then clamp, and then hand off. Now, when I initially started, I hadn't exactly thought about, obviously we had the obstetric tray there, and so we had the clamps available. But other things that you could potentially have if you were in the pre-hospital setting is just some sutures or something else. I think in most of the ambulances we've got some clips as well. Very quickly, so all of this happened in about less than 2 minutes for sure. The goal is less than a minute, which just tells you how fast you're going to be doing this procedure. But managed to take out Bob, clip, hand off to the NICU team, and that happened very quickly. We removed the uterus. And the other thing that I would mention at this stage is I hadn't thought about exactly where the placenta was going to be. In quite a lot of women, it's anterior and it's superior, so you're cutting right through it, which makes removing the placenta a little bit more challenging. So that was another step that the ONG team helped with us. Pack, and then we proceeded to manual aortic compression. A lot harder to find in the abdomen, which is perhaps my own ignorance, but just trying to find the way around the mesentery and which way do you enter and so wasn't quite as easy, but we got there eventually. And then Graham took over that procedure, and we applied some sterile packs to the abdomen, and then I returned to the head of the bed to see what was happening. So compressions were continuing. We'd managed to secure an airway, and the ICU ridge had failed on a central line, but had managed to put in a RIC line. Left lateral tilt was then resumed, and a gas was taken from a femoral stab. She'd had some bicarb, and some magnesium was already in, 4 grams. Some oxytocin was given IM after the delivery of the baby, and for what it's worth, she also got a unit of blood due to some concerns for bleeding. This was all happening, and unfortunately moved to the head of the bed and had a look with the ultrasound, and that stage she was in a systole and couldn't see any cardiac motion during one of our coach cycles. At this stage, we're probably about, I did it twice, so once right after the hysterotomy, and then again about another 10 or 15 minutes later. And there was quite a lot going on, as you can imagine, and was very task focused initially on the resuscitation, the resuscitative hysterotomy, and then back on to the overall resuscitation, trying to fuse in with the team. But it was quite clear that there was some subtext to the fact that, we were offering assistance for a dedicated procedure and not necessarily tasked to be in charge of this patient. And so there was just some cooperative discussion that for a clinical governance point of view, that we would wait for the FACEM to arrive. And she was a short time away. She arrived about 30 to 35 minutes into the resuscitation. We went through a review of what had been happening and decided to cease resuscitation efforts at that stage. That was about 45 minutes. Now, Bob went over to the resuscitator. Initially had a heart rate less than 60, had CPR initially, and had some BiPAP. And actually, speaking to the anesthetist involved, did reasonably well. Was intubated by NICU, and then unfortunately had another arrest. It was suspected that the tube had been dislodged during the CPR, so the anesthetist took over and then put the endotracheal tube back in, at which point they got a return of circulation, and the heart rate improved to 120 with a fluid bolus and adrenaline, and she went off to NICU. And we'll talk a little bit about her course after that. But from that stage, we were, optimistic about what was happening, but not naive to the severity of her potential injuries. So if you'll allow me, I'm just going to go through some of my reflections over the last 4 weeks, and hopefully that case sort of gives you an idea of the circumstances involved. And then if you ever find yourself in one of these circumstances, or just any other, life or limb-threatening saving procedures, perhaps it might be of help to you. And forever trying to adopt the sort of Wilco mindset as I move on in my career. And the first thing I would say is that I really believe that the training works. And I think something that we're taught is the 0-point survey, and alluding to something I'd said before, that this is a procedure like many of the others that you guys have done in your minds, in your 3D simulators, and it's actually that sort of mental modeling is very effective. When we think about the 0-point survey, obviously trying to optimize the environment, our self-performance, personal readiness, and participating in a preemptive sort of team brief. And I can't emphasize how valuable that 5-minute notification from ACC was for us, and certainly have tried to feed back and would encourage that in the future, if there's ever a circumstance where you could get 5 minutes of notification about anything, that time was hugely valuable, because it allowed Graham and I to sort of visualize and discuss what would happen, the practicalities of what we would do and how we would do it. And so that 0-point survey is, part of our training. And it took me right back to sort of week 1 or 2. And I'm not sure if you guys had the same thing, but here's a picture of Cliff on a whiteboard talking about that sort of step up mentality. And it really, there's a lot of things in there that sort of ring true. And I won't belabor the point, but suffice to say that, I use it, and I encourage everyone else to continue to use it. One of my reflections is also about this sort of positive mindset trigger. And it's all that sort of human factor stuff that this service is excellent at. And for me, my performance mentality is like there's a moment in time when you sort of set yourself ready to proceed to a performance or whatever the procedure might be. And for me, it's putting on surgical gloves when I'm, taking that time to undo the packaging and open it up. That's really when I'm starting to think about my performance mindset, getting into that mental state where you're ready to do whatever it is that's required of you. And take the plunge. This is a procedure where hesitation is really the killer. So you can imagine that if we'd waited, or you can imagine any number of situations where waiting for the O&G team, or maybe she's got some return of spontaneous circulation, and I know, Chris McClenahan is going to tell me about the case he had recently where, that hesitation saved the baby's life because they didn't do it and she recovered. But I would want you to leave today knowing that, this is a procedure which has a 50% survival rate for bub if done within the prescribed time limits, and potentially up to 30 minutes. So I'll talk about that in a minute. But the hardest thing about this procedure is like many of the other ones we do, it's really just deciding to proceed. And once you've made that decision, it's really quite straightforward. And that the reason we're doing this and the ethos behind doing it is you're doing it to save mom. It's a procedure done to improve mom's survival. And that's why you do it. Obviously, there's a nice ancillary benefit if you can save the child, but the mentality of proceeding is to save mom, and that's really what you're thinking about. But time is ever prevalent. So the traditional teaching, and I'm sure you remember from induction, the traditional teaching is arrest at 4 minutes, deliver within 1. But that evidence is poor. It sort of came out in the sort of 1960s from some case reports, and then by the 1970s it had been incorporated into the ALS algorithm that we should be aiming for 4 minutes. But the reality is that there's very good case reports of good neurological outcome for mom up to 15 minutes and for bub up to 30 minutes. And so they quote, some of the quoted percentages are 30% improved survival for mom and 50% for baby. Now that's pretty amazing. If you think of any intervention that we do during ALS and ALS2 management, there's really nothing that has a 50% mortality benefit. And so I encourage you to really keep this in your wheelhouse because it is a life-saving procedure. The next thing is speed, and I'm not going to labor this because I've already mentioned it, but you're aiming for less than a minute, and from incision to fetus delivery, that's really what you want to do. The type of cut, your incision. Now, I encourage you to spell phanestoel. I have no idea even how to spell it. But I don't think it's the right procedure for this. I don't think it's the right cut. I think some of the anesthetists, they've probably watched enough and they'd be comfortable doing that. But I'm not a surgeon. I'm not an obstetrician either. And so I would advocate for a big midline laparotomy in a cortisol-fueled session. I think that's what you're going to be able to perform effectively, and that's what you're going to be comfortable with. And I love this quote in reviewing for this paper. I love a big cut for a big problem. I think if you're in that situation, that's kind of what you'd like to do. Just moving back to a discussion that I alluded to before. Should this patient be supine? There is some evidence, some editorials in a lot of the papers, predominantly from North America, now advocating for a midline approach, and that's, I think, my view moving forward would be to use a left lateral tilt during the resuscitation phases, certainly during the first, I would say up to 15 minutes before the procedure, to attempt to offload the inferior vena cava and improve peripheral circulation and return of blood back to mom. But when we're doing the procedure, I wouldn't recommend it. I think that it's going to displace everything such that you lose some of your anatomical landmarks, and it can potentially make things slightly more difficult. Not to mention, if we'd had a return of spontaneous circulation in this lady, you are cutting through a lot more vessels, and there's a much higher propensity to bleed as well. So I think moving forward for me, I would do a supine approach, and I think that during resuscitation, I would still adopt that 30 degrees lateral tilt. The other thing which was notable was you can very easily, I suppose, use and move just with manual displacement. Pulling the abdomen off the IVC is probably the way that is also advocated now. So if you're going to do it, not necessarily doing it with sort of a towel or a wedge, but using sort of manual displacement. Just a couple more points, guys, and then I'll finish up. The last is that this is truly a team sport. We counted, I'm amazed reading that paper from 2010, but during the debrief, we had 36 individuals that were in the room for this resuscitation. And, some of those are probably observers, but I mean, I think that, there's a lot of people required to do this effectively, and just a lot of hands that are required just to hold, do retractions, manual compressions, and just the cycling through is really quite a lot of people. And so, I would advocate if it was in the pre-hospital setting, if you can, and if there's bandwidth to achieve it, I think that I would be asking for a second HEMS team potentially to assist, so that one for the procedure and one for the resuscitation. I am impressed, and I think it can be done as a solo team, but I think your bandwidth is going to be soaked up pretty quick. So that was the one thing. I sort of alluded to traction already, and manual displacement, so I'm not going to dwell on that. And the last 2 points. So one, I think, is the importance of debrief. We did a hot debrief on the scene, and I think there's a lot of ways to do this. Obviously, very emotive for people involved. And I kind of walked away thinking a lot of different things, but I think it's okay to feel good about delivering an intervention that has a potential, life-saving impact. And it's okay to have positive reflections about a case, even though it might not be the best outcome for the patient. But I think that for us, or for me at least, there's sort of 3 different debriefs. One which is a medical debrief, another which is probably an emotional debrief, and a third which is a performance debrief. And I think those are done in different settings at different times over the course of the following weeks, but is a valuable part of, I guess, performance optimization for the future. Now, this was 4 a.m, but in other patients with potentially similar physiology, I guess, in some ways, you might plumb them up and they might be ECMO candidates. And if it was in the middle of the day, 9 to 5, Monday to Friday, this is a patient that I would potentially discuss with the interventionalists or whoever in that institution might be doing ECMO. So potentially a future option. The other one is internal cardiac massage. We did manual aortic compression. We didn't do internal cardiac massage through the diaphragm, which is described and is potentially another very good intervention. And in reflection, probably would do that. I don't think it would have made a difference in this case, but is something that I would advocate for. And then I think that depending on what you think is causing the patient's arrest, manual aortic compression, I think, is still a viable option, depending on what you think the cause is, of course. So that kind of brings me to the end of my talk. Just happy to take some questions from the floor. I know it's been a bit of a bamboozle of slides there, but either from home or from the crowd. Happy if there's no questions as well.